Good afternoon. Thank you so much for participating in this very important conference and for your attention today. My name is Dr. Lisa Rosenfeld, and I am a psychiatrist at Cambridge Health Alliance, a Harvard Medical School teaching hospital. I am the medical director of our Health Integration Program, a behavioral health home serving individuals with chronic psychotic disorders. Today, I'll be talking about schizophrenia basics with the goal of helping primary care providers to feel more comfortable managing this complex yet very rewarding patient population. Specifically, I'll provide an overview of the epidemiology, diagnosis, treatment of schizophrenia, as well as important primary care and policy considerations in serving these patients. Let's begin with some epidemiological facts about this illness. Globally, the lifetime prevalence of schizophrenia is approximately 0.7%, meaning that 7 people in 1,000 will develop the illness in the course of their lifetime. This number has remained relatively constant over time. However, contrary to what was previously believed, there's considerable variation in prevalence estimates between geographic locations and subpopulations, both of which I will discuss shortly. The incidence in men and women is roughly equal. However, onset of the illness tends to occur earlier in men than in women. On average, men with schizophrenia develop symptoms in their early 20s, while peak incidence in women is bimodal, with a larger first peak occurring in their late 20s and a smaller second peak occurring in their late 40s. Further, despite equal incidence rates, men and women with schizophrenia tend to have different symptom profiles, with men experiencing more social withdrawal, substance abuse, and blunted affect, thereby resulting in greater social and occupational impairment and more severe courses of illness. Schizophrenia is among the most heritable of psychiatric illnesses, with a heritability estimated at 80%. At the same time, it's worth noting that schizophrenia is a polygenic disorder with more than 100 loci in the genome having been significantly associated with the illness through genome-wide association studies. Further, development of the illness is not explained by genetics alone, as there is only a 50% concordance rate in studies of identical twins. This last fact suggests that there are also environmental factors contributing to the development of schizophrenia. Known environmental risk factors, from greatest to least, include cannabis use, childhood trauma, urban living, migration, obstetric complications such as maternal infections, starvation during pregnancy, preterm birth and preeclampsia, and winter birth months in the Northern Hemisphere. Schizophrenia is a chronic illness with a relapsing remitting course. One study estimates that in people with first episodes of psychosis, good long-term outcomes occur in 42% of cases, intermediate outcomes occur in 35% of cases, and poor outcomes occur in 27% of cases. Several factors have been associated with a better overall prognosis, most of which are non-modifiable. These include female sex, rapid onset of symptoms, older age at first episode, predominantly positive symptoms, presence of mood symptoms, and good pre-illness functioning. One modifiable risk factor that likely impacts prognosis is what is called the duration of untreated psychosis, or DUP. It is clear that the shorter the DUP, the better a person's course. This underscores the critical importance of helping all types of health professionals to recognize the hallmarks of schizophrenia in order to expedite referral to appropriate care and reduce the social and occupational impact of the disease. Given the early age of onset, chronicity, and potential severity of schizophrenia, it should come as no surprise that the disease is associated with significant costs. According to a 2013 United States-based study, the annual economic burden of schizophrenia in the US alone was over $155 billion, which included $37 billion in direct healthcare costs and $117 billion in indirect non-healthcare costs, such as unemployment and productivity loss due to caregiving by family members. Perhaps the most important reason for including this talk as part of this conference on integrated care is the fact that people with schizophrenia suffer from higher rates of medical illness than the general population, with between 50 and 90% of patients having one or more chronic medical conditions. Compared to the general population, patients with schizophrenia have 2 to 3 times the risk of infectious disease, respiratory illness, endocrinopathies, gastrointestinal disease, and cardiovascular disease. Due largely to the burden of or untreated cardiovascular illness, people with schizophrenia die a staggering 15 years earlier than their counterparts in the general population. For this reason, it is of vital importance for primary care physicians to be able to recognize the signs and symptoms of schizophrenia, coordinate with their psychiatric colleagues, and ensure equitable medical care for all patients, regardless of psychiatric diagnosis. I think the authors of this paper, entitled Schizophrenia for Primary Care Providers, put it eloquently when they said, "To deliver effective medical care to those with schizophrenia, primary care providers do not need to be experts in the diagnosis of schizophrenia. Rather, primary care providers should have a working knowledge of the illness, its treatment, and the treatment challenges and health risks unique to this population." With this in mind, let's review the diagnostic criteria for schizophrenia. According to the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, a person with schizophrenia must exhibit 2 or more of the symptoms listed here for at least 1 month, with ongoing symptoms for at least 6 months, resulting in social and/or occupational impairment. At least one of the symptoms of an acute exacerbation must be hallucinations, delusions, or disorganized speech. And it's worth noting that acute exacerbations can last less than 1 month if they are being treated effectively. Regarding hallucinations, auditory are by far the most common type in schizophrenia. Patients with exclusively visual hallucinations should raise your level of suspicion for an underlying medical cause. Regarding delusions, these can be either bizarre, for example, aliens are trying to eat me at night, or non-bizarre, for example, my neighbor is trying to steal my belongings when I'm not home. Examples of negative symptoms include blunted affect, poverty of speech, social withdrawal, apathy, and anhedonia, or loss of pleasure. Of note, these tend to be the most impairing symptoms in the long term, and unfortunately are the least responsive to our current medications. In order to assess for these core features of schizophrenia, I recommend adopting a routine set of screening questions that are comfortable for you to recite, that normalize psychotic experiences, and provide patients with an opportunity to open up about the experiences that may be deeply distressing to them. I borrowed some of the following phrasing from the paper I already quoted on schizophrenia for primary care providers and adapted them based on my own clinical experience. I'd recommend beginning with a destigmatizing precursor, such as, sometimes when people are stressed or depressed, they have strange experiences, such as trouble with their thinking or noticing odd things in their environment. Has this ever happened to you? If a patient says yes to this, I'd follow with an open-ended statement like, please tell me a bit more. To screen for hallucinations, one could ask, has your mind ever played tricks on you? Have you ever noticed things in your environment that don't belong? Or have there been times when you heard or saw something that other people could not? I personally gravitate towards the last wording, since this suggests a sort of special power rather than a deficit, which people may be more likely to admit to. To screen for delusions, one could ask, have you ever believed something with all your heart, even when no one else did? This question, like the last one for hallucinations, validates their experience and may help people to admit to paranoid ideation. You could also ask, have you ever felt like you were being watched or followed? However, remember that for some people with trauma histories, answering yes to this question could reflect reality rather than a psychotic experience. To elicit what's called ideas of reference, one might ask, does it ever seem like the television or books, YouTube, have special messages just for you? And to elicit for what's called thought insertion or thought withdrawal, you could ask, some people tell me that they've noticed other people trying to steal thoughts out of their head or insert thoughts into their head. Has this ever happened to you? As an aside, I think using phrasing like some people tell me can help to normalize an experience and facilitate a frank conversation between patient and doctor. It's also important to screen for safety. 5% of patients with schizophrenia complete suicide, which is 13 times higher than in the general population. While patients with schizophrenia are more likely to be victims of violence than perpetrators of it, they are also 4 to 7 times more likely to commit violent crimes and 4 to 6 times more likely to exhibit aggressive behavior than people without schizophrenia. For this reason, primary care practices should routinely screen for risk of harm to self or others and establish a protocol for how to handle situations in which patients are deemed to be at elevated risk of dangerous behaviors. As with all psychiatric disorders, schizophrenia is a diagnosis of exclusion. Psychosis due to physiologic effects of a substance or another medical condition must first be ruled out. This is one stage in management where primary care providers can play an essential role. To begin, primary care providers must obtain a thorough medical history and conduct a focused physical and neurologic exam. Potential organic causes of psychotic symptoms include medication side effects, most commonly steroids or anti-Parkinsonian agents, as well as antimalarials and anticholinergics, intoxication, especially from cocaine, methamphetamines, or prescription stimulants, as well as hallucinogens, and also withdrawal from substances like alcohol and benzodiazepines. Infections, such as tertiary syphilis, HIV, or malaria, as well as delirium due to a systemic infection. Endocrinopathies like thyroid disease or hyperparathyroidism. Electrolyte disturbances, and neurologic processes, such as seizures, demyelinating disease, space-occupying brain lesions, Alzheimer's, or Lewy body dementia. To assess for these organic causes, one should obtain the following data during a first episode of psychosis: a current med list, a urine drug screen, a CBC complete blood count, HIV test, treponemal antibody, a chest x-ray if clinically indicated, thyroid function tests, parathyroid levels, and liver function tests, electrolytes and vitamin B12, ceruloplasmin to rule out Wilson's disease if clinically indicated, a brain MRI if there are focal findings on the neurologic exam, and if clinically indicated, an EEG and/or a lumbar puncture. Once the diagnosis of schizophrenia has been established, what treatment options exist? I'd argue that most of the care we provide can be divided into one of 3 categories, which are most effective when combined with one another. These are medications, psychosocial interventions, and team-based approaches to care. Again, in an ideal world, primary care physicians would not be the ones responsible for directing the psychiatric management of patients with schizophrenia. However, given the reality that some patients with psychosis will be reluctant to engage in psychiatric care, combined with a limited supply of psychiatrists, it is important for primary care providers to be familiar with these treatment options in order to help with basic management, side effect monitoring, and referral to appropriate services where available. There are many different medications coming in many different formulations used to treat schizophrenia. However, they all fall under the category of antipsychotic and are believed to have their effect through inhibition of the dopamine transporter. In other words, they're anti-dopaminergic. Essentially, selecting a medication comes down to two main branch points: whether to treat with a first-generation antipsychotic or a second, and whether to treat with oral medications, that is pills, or long-acting injectable medications, or LAIs, that is a shot. As a reminder, first-generation antipsychotics, also sometimes called typicals, are D2 antagonists and are associated with higher risks of extrapyramidal symptoms such as Parkinsonism and tardive dyskinesia. Second-generation antipsychotics, also known as atypicals, are both D2 and 5-HT2A antagonists associated with lower risk of extrapyramidal symptoms, but higher risk of metabolic side effects. While second-generation antipsychotics are now used as first-line treatment in clinical practice, largely due to the perception that there is greater tolerability, there is no evidence that second-generation antipsychotics are more effective than first-generation antipsychotics in the treatment of schizophrenia. And as a reminder, our existing medications are most effective at treating the positive symptoms of psychosis, such as hallucinations and delusions, while none are particularly effective at treating negative symptoms, such as social withdrawal, apathy, and anhedonia. This table provides an overview of the many antipsychotic medications that are available, divided into first generations on top and second generations on the bottom. My intent in sharing this table with you is not for you to have to commit the details to memory, but rather to highlight 1, the range of treatment options, 2, the idea that medication selection often comes down to choosing the treatment with the most acceptable side effect profile for any given patient, and 3, the idea that sometimes we select a medication for off-target effects. For example, quetiapine can be quite sedating and might be an appropriate first choice for someone with significant insomnia. Lorazepam, on the other hand, is used to treat bipolar depression and may be a good first choice for patients with significant mood symptoms. Although not typically used as first-line treatment due to its myriad side effects, I do want to point out that clozapine is considered one of our most effective treatments for schizophrenia and should be considered for patients who have not had a response to adequate trials of 2 or more other antipsychotics. Finally, the blue arrows here indicate the antipsychotics that are available as long-acting injectables, though not all of these are available in all countries. When treating a patient with a history of poor adherence or recurrent exacerbations, it is worth prioritizing treatment with a medication that can ultimately be converted to a long-acting formulation to prevent relapses and improve functioning in the long term. While pharmacotherapy is considered a mainstay of treatment for schizophrenia, it's also worth acknowledging and spending a few minutes on the growing evidence for psychosocial interventions. In a recent meta-analysis of psychosocial or psychological interventions aimed at preventing relapse in patients with schizophrenia, 3 approaches showed favorable results when compared to treatment as usual, that is, maintenance treatment with an antipsychotic alone. The figure here shows the odds ratios of relapse as compared to treatment as usual at 6 months in blue, 12 months in black, and greater than 12 months in red for each of the following: relapse prevention programs, family interventions, and cognitive behavioral therapy for psychosis, or CBTP. As a reminder, an odds ratio of less than 1 to the left of the vertical line indicates a reduced likelihood of relapse. I've included the reference for this meta-analysis for anyone interested in learning more. In brief, relapse prevention programs are interventions that include education for recognizing early symptoms of relapse, a system of symptoms monitoring, and a crisis plan in case the symptoms increase over a certain threshold. Family interventions are interventions involving the relatives of the patient, which can have several aims, including developing an alliance with the relatives who care for the person with schizophrenia, increasing the capacity of relatives to anticipate and solve problems, helping relatives to maintain reasonable expectations for patient performance, and attaining desirable changes in relatives' behavior and belief systems. CBTP involves establishing collaborative goals with the patient and incorporating therapy components such as improving existing coping strategies, developing and practicing new coping strategies, modifying delusional beliefs about hallucinations, and challenging maladaptive beliefs about oneself and the world. Some of you may be familiar with the English phrase, "It takes a village to raise a child." In much the same way, caring for patients with schizophrenia is most effective when done as a coordinated team. While both the primary care provider and psychiatrist play vital roles, neither is as effective in isolation as they will be if working together, not only with one another, but also ideally with other care providers, such as a therapist and a visiting nurse, community supports, such as family members, legal guardians who can play a vital role in medical decision-making, and staff members at group homes for individuals living in supported environments, and care coordinators, such as outreach workers and care managers, who serve as a vital bridge between community support and healthcare providers, and can also help patients devise plans and access resources to make progress on their personal, educational, and professional goals. Beyond understanding the basics of schizophrenia diagnosis and treatment, however, primary care providers have a very important role to play in attending to the physical health of patients with psychosis. After all, nearly a third of schizophrenia patients get most of their care in primary care. As already noted, patients with schizophrenia die 15 years before people in the general population, typically due to preventable medical illness. Premature mortality is due to a combination of lifestyle factors such as tobacco use, poor diet, and limited physical activity, as well as some of the medication side effects previously discussed, most notably weight gain, dyslipidemia, and diabetes, which are 1.5 to 5 times greater for patients with schizophrenia than in the general population. For this reason, routine medical evaluation and interventions aimed at reducing risk factors are of great importance when caring for patients with schizophrenia in the primary care setting. You may be wondering, what exactly should I be screening for and at what interval? I will review recommendations, again, largely inspired by the paper on schizophrenia for primary care in the coming slides. Note that when baseline is used in this table, it is in reference to starting an antipsychotic. The first recommendation is to screen for personal and family history of obesity, diabetes, dyslipidemia, hypertension, or cardiovascular disease when starting an antipsychotic and then annually. Next, it's important to screen for smoking status at each visit, as smoking is incredibly prevalent among patients with schizophrenia and associated with countless causes of premature mortality. As with all patients, it is important to counsel this group on the risks that smoking poses to their health and offer assistance with quitting. Treatment options such as varenicline and dual nicotine replacement therapy have been proven safe and effective for helping patients with serious mental illness quit smoking in large trials. It's also important to screen for weight at baseline, monthly for 3 months, and then every 3 months after starting an antipsychotic, as weight gain is associated with both lifestyle factors and medications common to patients with schizophrenia. For similar reasons to monitoring weight gain, it's important to measure blood pressure and hemoglobin A1C and fasting lipids every 3 months and then annually if normal, especially after starting a second-generation antipsychotic. Neurologic exams and standardized evaluations of movement disorders should be conducted every 6 months for patients on first-generation antipsychotics and annually for patients on second-generation antipsychotics to assess for medication side effects like tardive dyskinesia and Parkinsonism. Of note, the Abnormal Involuntary Movement Scale, or AIMS, is a structured questionnaire filled out based on a treater's observations of a patient's facial, truncal, and extremity movements, both when seated and active. This assessment tool can be easily found through a Google search. Medical providers might also obtain an ECG, prolactin level, or conduct an eye exam depending on medication-specific risks and patient-reported symptoms. Finally, it is important to make sure that patients with schizophrenia receive vaccinations and cancer screenings following the same recommendations for people in the general population, as they tend to access preventive services at lower rates and are at increased risk of both infectious disease and cancer. It is also important for primary care providers to understand some of the most common barriers to care for individuals with schizophrenia, both in order to facilitate empathy for the challenges that patients face and to address barriers that are within their control. First, a patient's symptoms may interfere with their ability to engage in care. For instance, paranoia may make it difficult for a patient to be honest with a provider about how they're feeling and what their concerns are. Cognitive impairment and disorganized speech may limit a patient's ability to provide an accurate history or describe their symptoms in terms that make sense to their provider. Negative symptoms, such as amotivation and apathy, may get in the way of attending appointments or adhering to treatment recommendations. Finally, comorbid substance use may limit adherence to treatment and lead to treatment-interfering agitation or impulsivity. Providers, as well as people in the general public, commonly stigmatize people with schizophrenia. This can interfere with treatment, both on the patient side, that is, patients may not want to seek care from a provider who they believe holds a negative view of them, and on the provider side, through avoiding these patients either consciously or unconsciously, and offering them briefer, more limited care when they do engage. As a note, this is natural human behavior. Who here can honestly say that they haven't felt relief when a patient who's interpersonally challenging or engaging in dangerous behaviors does not show for an appointment? My intent is not to make you feel shame for having these feelings. We all do. It's to challenge you to recognize it in yourself and realize that you have to work extra hard, not less hard, to re-engage these sorts of patients and ensure they access appropriate care. Another cognitive trap that physicians commonly fall prey to is diagnostic overshadowing, or over-attributing a patient's complaints of physical symptoms to their mental illness. If this tendency goes unrecognized, it can exacerbate the existing morbidity and mortality gaps for patients with schizophrenia due to delayed diagnosis and worse outcomes. Finally, providers may experience what's called therapeutic nihilism, in which they underestimate the capacity of their patients to participate in their own medical care, thereby leading providers not to offer the care at all. This may contribute to lower rates of preventive care for individuals with schizophrenia and likely results in fewer medical interventions being offered to these patients. For those in attendance who work at the systems or administrative level, I just want to spend a moment to highlight some of the policy considerations that can help improve care for individuals with schizophrenia. First, at present, navigating a complex and often fragmented healthcare system can impede access to care for individuals with schizophrenia, especially due to their risk of negative symptoms and cognitive impairment. Incorporating the use of care managers to help patients schedule and keep appointments, follow up on recommended tests, and coordinate between providers could generate enormous value for this vulnerable and high-cost patient population. Further, integrating psychiatric care into primary care settings, as the organizers of this conference are so clearly committed to doing, can help ensure access to holistic care and improve communication between medical and psychiatric providers. Second, Offering providers continuing medical education like this course will help to raise awareness about barriers to care, increase provider comfort in treating these patients, and hopefully decrease the stigma associated with serious mental illness like schizophrenia. A third policy intervention would be to conduct public awareness campaigns to educate the general public on the prevalence, signs and symptoms, and treatment options for individuals with schizophrenia. Similar to provider education, the hope is that public awareness campaigns would drive down stigma and increase individuals' and families' willingness to seek care for serious mental illness. And while on the subject of families, I would also encourage policymakers to support flexible models of care that promote family involvement and potentially community-based teams that can provide in-home services to address the needs and questions of patients and their support systems whenever and however is most convenient. Finally, in caring for patients with schizophrenia, and frankly, with any mental illness, policymakers should think beyond the medical system and strongly consider financing efforts that promote recovery in the areas of education, employment, and social skills. In doing so, they not only stand the best chance of decreasing the costs associated with caring for this patient population, but also honoring their integrity and humanity. So before I wrap up, let's review some key takeaways. Schizophrenia is a universal and relatively prevalent illness associated with significant morbidity and mortality. It is essential for primary care providers to know how to diagnose schizophrenia, assist with ruling out medical or secondary causes of psychosis, be aware of treatment options, coordinate with the psychiatric team and community supports, and monitor for and treat cardiovascular risk factors that are ubiquitous in this population. Courses like this are essential for increasing comfort with treating patients with schizophrenia and reducing stigma. And finally, policymakers also have levers both in and out of the medical system to improve quality of life for individuals with schizophrenia. Over the next few slides, I'll share some of my references, which I'm more than happy to make available after this talk. And finally, I'd like to say thank you again for your attention and your attendance. And I'd like to open it up for questions, comments, or any ideas you might have.